Well, good day, everyone. My name is Morton Pulse, and I'll be hosting today's webinar. I'm the Director of Communications for the School of Public Policy at the University of Calgary, and I want to thank you all for joining us today. We've got an exceptional turnout for this webinar, and I think you'll be pleased with the content. Robert Falconer is one of Canada's leading experts in immigration, refugee, asylum trends, so we're fortunate to have him today. Just a few words about the School of Public Policy. The School of Public Policy is Canada's leading policy school. We're known for our practical research and for bringing people together to discuss the important issues of the day with leading experts, which is why we're here today. Pleased to welcome you to the third edition of this new series of webinars hosted by the school to provide expert commentary on issues that are impacting all of us on a daily basis. The school has done a rapid transition and a pivot towards issues related to COVID. That's not dominating all of our research, but there's no question that we are focusing on the issues that you're concerned about in terms of the social impact and the economic impact of COVID. And I know that Robert's going to touch on that. If you miss part or all of this recording, or if you want to recommend it to somebody else, you can find it on the School of Public Policy's YouTube channel. You'll also be getting a link in a follow-up email. The topic of today's webinars is Immigrant Doctors in Canada Lifting Red Tape to Timely, Safe Accreditation of Healthcare Professionals. As I mentioned, our speaker is Robert Falconer. Robert is a talented research associate in the Social Policy and Health Research Division here at the school. His primary focus is immigration and refugee policy, with a recent focus on the inclusion of immigrants and refugees in social, health, and economic life in Canada, and also the involvement of volunteer groups in resettling refugees. Excuse me. Robert holds a Master of Public Policy from the school and an honors Bachelor of Anthropology from the University of Toronto. Robert has previously worked directly in the settlement process of immigrants as a frontline worker at Calgary Catholic Immigration Society. So in terms of the format today, Robert will take about 10 minutes to give you a briefing on this issue, and then I'll open it up for audience Q&A, which I will moderate. If you have questions, you'll see a Q&A box. Please type your questions in there, and I will pose them to Robert as best I can, covering as many questions as I can. At this point, I will turn my video off and turn this presentation over to Robert. Robert, if you would, please.
Thank you, Morton. Welcome all. Happy to be talking about this topic today. And we're going to start off before the Q&A portion of the session by talking about some broad level trends, both here within Canada as well as around the world, both as it relates to the arrival of immigrant and refugee doctors to Canada, as well as how doctors and other healthcare professionals are getting involved in the fight against COVID-19. So I'm going to turn on showing my screen here in a second. This is just going to provide just some summary statistics about the number of immigrant doctors and healthcare professionals that have arrived to Canada within the past few years. So as you can see here, this here shows the number of landed immigrant physicians by province. This is from January 2015 to January 2020. The way we have collected this data is this from the IRCC. They provide monthly updates on the number of immigrants who arrive within Canada. And specifically, one thing they ask them is their intended line of work. Now, this is different from what they'll actually work in, and this will be, of course, a big theme of today's topic. But they do ask, what does the immigrant intend to work in? These are the number of immigrants who intend to work as physicians, either as general practitioners or as specialists within Canada. The big purple chunks here in the middle are central Canada, that's Quebec and Ontario. Quebec is right here, Ontario is right here. The green chunks towards the top are the prairie provinces, Alberta, Manitoba, and Saskatchewan. Yellow is British Columbia, and at the bottom here in the blue is Atlantic Canada. So we can see the lion's share of immigrants, physicians do go to central Canada, but a not inconsiderable number also go to Western Canada as well, including both the prairies and British Columbia. And that translates to about a little under 1,000 immigrants per year that are intending to practice as physicians. To put that in perspective, that's about a third of what we graduate from our medical schools here in Canada every year. So we graduate about 2,900, about 3,000 new doctors every year who go on to do their residencies. And we also receive about 1,000 or so immigrant physicians per year. Again, I just want to reemphasize, those are immigrants who intend to practice medicine or hope to practice medicine. It doesn't necessarily reflect the number who will actually end up practicing medicine. Now, what does it take to become a practitioner here in Canada? We'll go over this really quick, and this is from the Alberta International Medical Graduate Association. So I want to thank them for providing this on their website. Very quickly, the first thing that an immigrant has to do is they have to register with Medical Council of Canada. That's through their website, physiciansapply.ca. That's where they submit all their credentials for assessment. They will then apply through the College of Family Physicians and Surgeons of Alberta, or the AMNG program. Now the difference here, and this is where we'll get into some of the difficulties that immigrants face, is that in order to be able to do what's called a practice ready assessment, this is where you're able to sort of very quickly, very rapidly operate independently. You have to meet all the requirements of the college here in Alberta. And a big requirement is a 2-year postgraduate medical education. That would be what we call the residency. In many countries, that's not a requirement in order to practice medicine. So alternatively, AIMGs, these are the Alberta International Medical Graduates, can apply for a residency, a 2-year residency here in the province. That comes with some strict barriers. Among them are, of course, having your credentials assessed properly, but also there's a 24-week residency requirement in the province, even prior to beginning that. So that means an immigrant has to live within Alberta for at least 24 weeks before they can even become eligible for that residency program. They have to pass through a series of interviews that, again, sort of assess the quality of their education. They are matched with residency programs, and they then have to complete a 2 to 5 year residency program. At the end of all this, they have to register with the College of Family Physicians and Surgeons, the College of Family Physicians of Canada, or the Royal College of Physicians and Surgeons of Canada, and then to be able to practice fully here within the province. Now, of course, the other issue here at hand is that we're not only just talking about immigrant physicians today, but we're also talking about the larger number of healthcare professionals by province. In this, Quebec, that big blue bar there in the middle, is the highest receiving province in all of Canada. And among these are included nurses, lab technicians, pharmacists, as well as doctors. As you saw previously, while Quebec receives a low number of physicians compared to the rest of Canada, it actually receives a high number of other healthcare professionals. And this was actually brought up to me the other day by somebody who emailed me in relation to one of our pieces, bringing up how if we truly want to move on with COVID-19 in the long term, or at least in the medium term, we're going to have to quickly ramp up testing to be widely available to all Canadians, so we can more accurately target those who are in need of self-isolation and self-quarantine. Now, responses to this. So we know the number of immigrant physicians here in Canada. Again, roughly about 1,000 per year who immigrate here, and about 4,500 other immigrant professionals. How do we involve them in the fight against COVID-19? Well, I want to provide just a quick overview of how other jurisdictions are responding here, because a number of other jurisdictions are really quickly moving to facilitate the inclusion of immigrants within their healthcare systems in response to the pandemic. So we have a bit of a spectrum here. On the one hand, we have examples like New York and New Jersey in the United States. These are probably the most permissive moves different jurisdictions have done. New York has moved to allow international medical graduates to practice without a license, so long as they have at least 1 year of graduate medical education. New Jersey is allowing international medical graduates to practice as long as they have a license in another country. Then you have a middle tier that I've calling the associate or attaché model. This is being done in areas like Ontario, British Columbia, and France, where they're basically allowing immigrant physicians who meet most of the qualifications. This means having passed most of their medical qualifying exams, along with a few other requirements, in order to practice as sort of an associate physician model under the supervision of a full licensed physician. Again, this is being practiced. The first one that I know of that started this was France, but both Ontario and the BC colleges have made moves to amend their bylaws or permit otherwise immigrant and other internationally medically trained physicians to practice under this, again, this associate model. And then finally you have, I don't want to call this the most restrictive model because again, it is a move to greater inclusivity with regards to physicians. But you have the Irish Medical Council model, which is decided to waive fees and expedite the review of applications from international medical graduates. And right away, they've actually looked to hire refugee and asylum seeker healthcare professionals to work in unlicensed positions such as healthcare aides. So and this is the spectrum of moves being done by other jurisdictions. Here in Alberta and in most other provinces of Canada, we have policy levers either within the colleges or within the provincial health ministries in order to make some of the main moves. You have, again, this break glass response, sort of similar to the New York and New Jersey model, where the health minister could theoretically waive a lot of the requirements for international medical graduates to be able to practice as well. But then also you have, as exemplified by British Columbia and France, you have this move by the colleges themselves to facilitate, again, this associate physician model. This is a very broad topic and 10 minutes is not quite enough to go into all the ways we could reform this system. But I just want to summarize it in a few things. Is one, long-term Canada should consider the costs associated with accreditation. It is quite an expensive process. It can take up to about 42% of an immigrant's annual median income. And we should consider also the rapidity. A lot of other jurisdictions such as Norway and Sweden have implemented statutory assessment periods that really require the medical colleges within those jurisdictions to provide a timely, transparent process to this. Thank you. Again, broad topic, but we're going to open up for questions.
All right, that's excellent. Thank you, Robert. I'll remind the audience that there is a Q&A box, Q&A icon rather, at the bottom of your screen. If you click that, that'll open up the box so you can type in your questions. We've got some coming in now, but you can type in your questions and I will moderate and pose those to Robert. We've got a couple in already. Question for you, Robert. Does the number of incoming immigrant physicians that you indicated, could that include Canadian students who've gone abroad to study medicine?
No, so those numbers that I provided in the graphs here, that would only include immigrant healthcare professionals, those who intend to come here.
All right, so that's not Canadians who've gone abroad. Thanks for that. Can you outline how long does it take in total, given the various steps, for the typical immigrant physician to get accredited in Canada?
So it's a bit of a range. On average, you're talking about maybe 3 to 5 years. Again, this is largely dependent on the ability of an immigrant to get their credentials assessed rapidly, but then also for quite a number of them, they also have to go through this 2-year residency requirement. So about 3 to 5 years, but this is along a range of about 1 to 10 years actually. So you can have some immigrants from some jurisdictions such as Hong Kong, the UK, et cetera, who by the national colleges, the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada, they have steps in place in order to ensure people from places again like Hong Kong, the UK, are able to practice in a more rapid fashion. So they could be on the lower end of that 1 year that 1 to 10 year spectrum. But then you could have others who again, they will eventually be recognized, but between getting the credentials assessed, getting a residency, and getting fully licensed, it could take up to 10 years.
Okay, thank you. That's a good segue, and it begs the question, is there good reason for a slow and deliberate reaccreditation process? Could it be that some international accreditation are better or worse than others, and should Canada take due care in accrediting foreign healthcare workers?
Absolutely. I think due care is warranted. I think there's an inclination here whenever we talk about reforming our accreditation system to think that that means that we're going to throw accreditation out the window and start allowing doctors to practice unlicensed within Canada, whether internationally trained or otherwise. And certainly, I think New York and New Jersey provide, again, that break glass scenario where the situation is considered so extreme that they're just trying to involve doctors in any way they can. I think some level of care is warranted, but I do think there's opportunities to make it a faster process. The examples I'll give is actually Norway and Sweden. So Norway and Sweden both have a higher number of doctors per persons. Where Canada sits at about 2.8 doctors per 1,000 Canadians. Norway sits at about 4.8 and Sweden sits at about 4.1. They also have a higher proportion of foreign trained medical professionals there. And if we look at the demographics of those foreign medical trained professionals, about an equal number of them go to those countries as they do from low and middle income countries as they do to Canada, meaning that if we're talking about quality of healthcare, Sweden and Norway are expediting the inclusion of foreign trained medical professionals in a faster and timelier manner than Canada is. And when you do, the studies that have looked at this have found no significant difference in the international medical graduates that end up getting accredited in Norway and Sweden to places like Canada and the United States, that the mortality rates are equal and the patient care quality is roughly comparable.
Okay, and in terms of patient care, obviously communication is critical between a health worker and his or her patient. Can you speak to the language requirement, how onerous that is? Is that still mandatory?
Yeah, so there is a language requirement. It's through the IELTS academic exam. I think, of course, having an ability to communicate in one of Canada's official languages is important. What I'll emphasize, especially with a lot of family clinics, is that most college registrars will list the languages that are offered by physicians. Meaning that a good portion of an immigrant's clientele in a family clinic setting is going to be from immigrants from their own countries, who are specifically going to those clinics because they want for example, a Punjabi speaking doctor, a Spanish speaking doctor, etc. Still, again, I'll reiterate, I think it's important for practitioners to be able to serve Canadians who speak one of the two official languages. What I'll say though is that for a significant number of immigrants, they will have already completed a preliminary official language test as part of their immigration process to Canada. Under our economic class streams, most of these streams require an English or French test in order to immigrate to Canada. And I think there's I'll say that's a general language test stream. That's distinct from the academic IELTS. But I can see the opportunity, maybe it's a reform at the national level to accept the academic IELTS as an official language test in support of an immigration application to come to Canada. That would help hopefully facilitate, at least, rather than duplicating multiple official language tests, provide opportunity to simplify that process at least.
All right, excellent. Listen, this is great, Robert. We've got a bunch of questions pouring in, so I'm going to hit you with them kind of rapid fire. And if you can give us nice, tight answers, we'll try to get through. They're pouring in. We'll try to get through. Physician healthcare worker costs are a huge part of the overall budget of the healthcare system. Imagine that we did quickly certify a lot more healthcare workers. Can we afford that within the current spending budget for healthcare?
Well, I'll emphasize right now, especially as this relates to COVID-19, that there are economic costs associated with not addressing the pandemic. And so it's one of those issues where, yes, it's money up front in order to involve the inclusion of more immigrant healthcare physicians, but it's money saved downstream by being able to address the pandemic in a more rapid manner.
Excellent. Oh, sorry, Robert, go ahead.
No, I'll just say that I would say that the inclusion of immigrants within the healthcare system is sort of we shouldn't necessarily conflate that with the healthcare budgets. The healthcare budgets should be something we should address outside of that, within the different funding models of how we pay physicians. And there was, by the way, an excellent paper by Jen Zwicker and team yesterday talking about how we fund physicians' positions.
No, that's quite right, Robert. And you can find that paper as well as Robert's policy trends paper that this talk is based on at policyschool.ca. Look on the front page, scroll down a bit, or just go to publications. You'll find those two publications and other recent publications there. Now, in terms of current healthcare workers, I've got one question here that suggests that a third of physicians already practicing in Alberta may be immigrants. Do you have any data on that, Robert?
No, that's quite right. Nationally, we're seeing about a quarter, about 25% of immigrants are internationally trained. In Saskatchewan, by the way, in Saskatchewan's even higher. In Saskatchewan's about 52% of healthcare physicians there are internationally trained. So I think there's opportunities to increase that. I'll point out that again, Sweden nationally is still even higher than that. So I think again in Alberta, we can use Alberta as an exemplar for the rest of Canada. Certainly on a national scale, we can certainly ramp that up, and even Alberta has room to include more immigrant healthcare professionals.
Excellent. I've got a question here, Robert, from somebody who actually works in the immigration field outside of government, and is wondering if there's anything that those folks can do to help expedite the accreditation process for people who want to move to Canada and practice.
Yes, absolutely. I think they're making more pre-arrival services available for immigrants. I think is especially important. What that basically means is making them aware of the steps they're going to have to face when they get here. Consistent among all the literature on the subject is the shock that a lot of immigrant physicians face when they get here and they realize all the steps that are entailed with taking these, and also the huge financial costs. I think as well, it's important to point out the immigrant service sector has a huge role in advocating for immigrants in these areas. One area that we haven't touched on yet that I think they could actually provide a lot of support in is financial support for certain categories of immigrant physicians. I'm specifically thinking of refugees and asylum seekers. To give you one example, I was talking with a lawyer here in Calgary the other day who works in the immigration sector, and one of their clients who is a refugee from Colombia who's recently received protection from the Canadian government. They're currently driving Uber, and they were a cardiovascular surgeon in Colombia. They could very likely pass the exams here in Canada, and they speak fluent French and fluent English. But the cost can range both in terms of just raw fees, books, as well as the foregone costs in terms of transportation, et cetera. They can range about $15,000 to $28,000. And I find it difficult to believe that somebody driving Uber would be able to meet both their regular necessities of life as well as also the costs associated with that. So there could be an opportunity for the immigrant service sector to lobby, at least whether it's microloans, some sort of grant, a refugee physician grant, I think would be an opportunity for them to work in that area.
Good answer. Now, what about seeking foreign accreditation in the US first? Is that any faster? And does US accreditation carry any weight in the Canadian system?
So yes and no. US accreditation is a little bit faster, and they do have somewhat more foreign trained professionals than Canada does, as far as those who are actively working in their fields. If they had a 2-year residency within the US, that could help facilitate their inclusion within the Canadian medical system, because again, that's a big hinge point. That's one of the big barrier points for immigrant physicians seeking to practice in Canada. So again, if they have a 2-year residency within the US, then yes, that could absolutely help. If not, if for some reason an immigrant physician was working in the US and then they wanted to come up to Canada, again, there'd be that barrier to residency. That would be the difficult portion there. And that question of residency is both a question for both the colleges, but also for the provincial governments in how many residency spots they choose to fund for international medical graduates.
Yeah, and you talked about changes in the process in Ontario and British Columbia. Are those provincial changes being made known abroad? Are there folks in government or in other sectors that are communicating those changes in the provinces to healthcare practitioners abroad?
So within the different ministries, I have not seen those, again, within the ministries or within the colleges. I know that at least here in Alberta, they're made aware of it. There have been a number of news pieces that have come out in the past week related especially to the publication of our piece, in which the College of Family Physicians of Alberta has engaged with those. So I know they're aware of it. More broadly, I think there could be opportunities to make this even more well known. I actually think the associate attaché model is one that, again, being done in BC and Ontario, maybe one that's worth considering here in Alberta and other areas. Again, that's that model where a physician can work in a limited fashion under the supervision of a fully licensed physician. And I think that could be an opportunity to rapidly scale up. And again, I'll just say with the BC and Ontario model, in both cases, the doctors will have to have passed most, if not all, of the other credential assessments. It's just that they haven't had perhaps that residency piece yet. And it's that blockage that's sort of being overcome with the associate model.
Excellent, thanks. What about the various specialties? Does the time required to get accreditation vary by medical specialty? And I'll take that a step further. Does it vary for doctors versus nurses versus pharmacists, et cetera?
Yeah, so if you want to specialize, that is an additional step there. And actually, as a result of that, a number of specialists in other countries end up practicing just as family physicians or practitioners here in Canada. And I don't want to undermine the work that family physicians and practitioners provide. More than anything, just to emphasize that because it can take an extra length of time and money. That's where you start to get up into that mid $20,000 to high $20,000 range in both time, in both money and then time. It can get up to that 10-year phase. That's where again you're losing out if specialists who may be very well qualified can't practice in those specialties here in Canada. And then certainly for nurses and pharmacists as well, the barriers there aren't as onerous, but they're still there. Again, there's this whole credential assessment piece that can take both time and money. Yeah. And certainly each college should consider how they can move those. I actually think, again, one of the ones that I think should be seriously considered is also the laboratory technologists. These are those who are helping test COVID-19. Mm-hmm. And I think there's opportunities there to actually rapidly increase the number of laboratory technologists to be able to help testing in this area.
Here's a good question. How true is it that IMG's international medical graduates, and by the way, Robert, we've got about 5 minutes, so I'm going to try to get through as many of these as I can because we still have a lot coming in. How true is it that international medical graduates, having passed their examinations and made it through the system, are still on a quota system that prioritizes local medical graduates over immigrant medical graduates?
Well, again, I think if we're talking about they pass everything up into that residency requirement, that is still the case where there is a quota. Now, the reasons for that quota, there might be reasons related to, again, you have a limited number of funded residency spots, and so you want to prioritize your local graduates. But when we say quota, what we mean by that is there's a restricted number of residency spots for IMGs, for these international medical graduates. Mm-hmm. And I think that raising the number of spots available, again, is both a question, is more of a question for the relevant provincial health ministries. And again, we might also want to consider to what extent is the 2-year residency requirement something we want to consider revisiting is with regards to international medical graduates as well, if they've been, for instance, practicing for X number of years.
For sure. Here's somebody who wants to help, Robert. And this is an anonymous question that reads, I'm an IMG with advanced training and expertise in epidemiology, looking forward to participating in COVID-19 response in Alberta. Since this is not patient care, is it possible for me to render my services during the pandemic?
So I'm not going to give my response. I'll give the response I've seen from the college, which is the college requires in order to deliver restricted practices, the college requires you to meet all the criteria, all the eligibility criteria, including passing the medical exams and either a practice-ready assessment or that 2-year residency. I think there's certainly opportunities to work in more what we might call lower tier healthcare settings. And when I lower tier, I don't mean in terms of the work they do and the importance thereof. I think more just less restricted ones. There is, for example, a healthcare assistant or a clinical assistant area, which sort of you go through some of the steps involved with becoming fully accredited and licensed here in Alberta, but it allows you to do things like, for instance, take patient histories, do some basic work around that. So there's opportunities there, and of course, as far as research goes and as far as public health research goes, I think there's plenty of opportunities there. And NAHS, I think, is certainly called for people who are interested in helping out in COVID-19 to let the AHS services know.
Okay. Is it possible or advisable for provincial bodies to relax current policies and permit foreign doctors to practice medicine as general practitioners? And the question reads, under the supervision of a licensed doctor on a contract basis, say 5 to 3 years, in remote locations?
Well, again, I'll just use the example of Ontario and BC, where they've already done that in response to COVID-19. They've implemented this associate model of working under a fully supervised physician. So it's not necessarily my answer. It's their answer. It's the answer of these different jurisdictions saying that yes, there is opportunities here for IMGs to be able to practice in a limited capacity as these associate physicians.
Okay, I'll give you one last question because I'm being prompted to, unfortunately, close this off today. Nurse practitioners, pharmacists, etc., argue that their scopes of practice should be expanded to address the additional need for healthcare given the COVID-19 emergency. Thoughts now on whether or not the current system could allow those classes of practitioners to expand their scope of work?
So I'm going to be careful here with this one because again, my wheelhouse is immigration and refugees, not necessarily the healthcare system. What I will say is that when there's this break glass option here, the provincial health ministries, if serious enough, in a public health emergency, the health ministers could allow normally restricted activities to be performed by certain persons or categories of persons. So for example, if they wanted to expand that to nurse practitioners or IMGs or whoever else, they certainly could. I think that's sort of what's being done in New York and New Jersey. I think that's a break glass moment, but I go back to, again, I think long-term, medium long-term, whether it's rural healthcare or other areas of need, the one I think that we've set a precedent for now here in Canada, BC and Ontario, the associate model, is one that we can see how that works out. And I think that there's opportunity to roll that one out in the long term. Again, let doctors, international doctors and medical doctors practice in this associate form under full practitioners and see if that we can eventually transition them to a fully licensed doctor, and perhaps that could be expanded to other professions as well, including nurse practitioners. But again, I'm going to refrain from commenting more on that simply because it's not my area of specialty.
Yeah, no, that's entirely fair, Robert. Listen, I want to thank you for the research that you've done for today's presentation. I'd like to thank the many people who joined us for the webinar today and the many folks who sent in questions. I want to apologize to anyone whose questions we did not get to. But listen, Robert's contact information is on the website of the School of Public Policy, so is mine. If you've got outstanding questions that you think need to be answered, feel free to reach out to us. I'll remind everybody that Robert's research and the rest of our research on COVID and on other issues is available at www.policyschool.ca, then click on publications. This is one of many regular webinars on a variety of topics that we're going to be hosting, so please keep an eye on the website as well. In the events section, as webinars get announced. We hope that many of you can join us for those. The next one is Thursday, April 9th. That one is going to be focused on the issue of international trade, which I'm sure all of you will agree is becoming more and more important, not just in terms of revenue generation for Canada, but in terms of supply chain and keeping the borders open. Robert, thanks again.
Thank you, Morton.